We should have a radio show.
So again, just to reiterate for the recording, I guess that today's conversation is about mental health options and supports for refugees in Kingston.
And we're just going to run a quick poll, if that's okay.
Just to see who's here.
Yeah. Who's in the room?
So tell us who you are.
So there's 1 settlement worker, 2 settlement worker, 3 settlement worker. Oh, sponsors are catching up. Sorry. Okay, maybe I want to do a horse race thing. Oh, there's more sponsors. So right now, there are 8 sponsors in the room, 4 settlement workers. We got a couple service providers and some community advocates. Of course, you can also vote in multiple categories because most of us are probably more than one.
I did what I
Perfect. And here, just so everyone can see, so sponsors are clearly the majority here, which is really cool.
Great, thanks for doing that. So we've got 3 special guests today, but everyone is welcome to participate and join in the conversation. For our first guest, and a couple will be joining us later on. So first we have Tabitha McInnes, who's here from the Maltby Center. And we're gonna ask her some questions and just to get the conversation rolling. And feel free to join in and ask other questions as we go. So first of all, Tabitha, tell us about Maltby Center and what your services are for newcomers and their families.
Great. So Maltby Center, if people aren't aware, we used to be called Pathways for Children and Youth, and we're the children's mental health agency in the KFLNA area. So we have offices all the way up kind of in Flinton area, so up Northbrook area, and we are in Napanee and Amherstview, Sydenham. Where else are we? I think that's it. Kingston. We amalgamated our Kingston offices. So we serve a wide area, but we don't serve everywhere. So we aren't children's mental health in Hastings, Prince Edward, but there is children's mental health services specific to that area, if you know families in that area. So we serve that population. I've worked at the Maltby Center now for about 15 years and work with a very small team, a volunteer team. MALTBY Center TRE. So I work with a very small team of volunteer counselors that decided we wanted to have newcomer families as a part of our complement when they're referred, because what I felt strongly about, and the manager who's supporting this, is that this is a population that needs to be served and supported in an informed and specific way. However, the services we provide for newcomer families is what we would provide for any family. So typically in children's mental health services, a mental health challenge is being identified for a family, and that typically looks at some social and emotional concerns for a child, perhaps some developmental concerns. We don't specialize in developmental services, but we support an understanding of development and where to access other supports if there's a developmental concern with a child. We have, I'm also part of a specific trauma group at my work. So we support families who have been impacted by their experiences in a negative way. And so that would be something I think can be typical to some of the families that we serve as newcomers. And so there's a bit of an overlap there in those two groups. All families are entitled to parent education programs when they come in. There's lots of parent education programs. We don't currently run parent education programs specific for newcomers. However, we have done a couple of community outreaches where we've offered a day for resettlement workers to support newcomer parents coming, to give them more information about Maltby Center, and we've been invited to attend or present information at think one was at an ESL program to parents and families to just give them more information about children's mental health services and how we can support. Typically, kids are having challenges, and we end up getting flagged in as somebody that might be able to help in some way in relation to parenting and supporting that child. Is that good? I don't know.
That's great.
Yeah.
So, and as far as like refugee children or newcomer children, how have you served many in our community in the past, or?
Well, I think our ratios for how many families might need some support versus referrals is quite low. There is, I think we're trying to look at different ways to branch into existing services to connect more with families, because I think part of the process of getting resettled is having environments that you feel safe and familiar, and then having the service come to that environment as opposed to coming to another building. So I think I think there's a number of reasons, but ours have been low. I've had compared to my regular caseload, quite low, and I think all of the counselors associated would say it would be low given how many newcomer families are in our community. And then I think the other piece that sometimes happens is and I think it's important to recognize, is that like any volunteer service or a service that involves so much engagement from a parent,
Sorry. Thanks, Michelle. When I went on the website to do the order the candles.
You can probably just mute her from your end, Euchre.
Yeah, we got that.
Just the thing.
Okay.
That's right.
It always happens. I'm always like on the work Zoom when we have our 100 meetings, I'm like, mute yourself. You're gonna yell at your dog or something. But yeah, like, so what I have seen is like community deciding that children's mental health would be really valuable for a family, but then maybe not some other things being addressed first that were really valuable to address, like some other social supports in place, a better relationship with the school, or even housing or financial stuff that tends to be such a priority, no matter what we see as being, a children's mental health issue, or maybe, an issue related to something like trauma or parenting or whatever. There's sometimes an issue with readiness or understanding of services. So I think part of it is making sure the parents know that they will be supported. I think that was the question there just about language.
Yes.
Part of that, yeah.
Yeah.
Sure.
So yeah, there is. Thanks for the question. I can kind of half read and talk, but my brain doesn't always work. Well, now let me just pull up my chat so I can see it better.
Can you provide service to families in their first language? We can
Yes.
read it out to you too.
Yeah. Yeah, I've got it open now, so it should be okay. It's not just popping up and going away. So we can. So there is then just kind of a bit of a delay sometimes in accessing the translation services. So we don't have, which I think is still a barrier, but we don't have specific counselors speaking in different languages like we do. We have 2 designated French language counselors. So if you're French, then that's an option. If French is primarily your first language, but we work with interpreters primarily for other languages right now, varying from many different countries. So.
And how does that seem to go? How does that work out?
I think it works out well. We have some good interpreters. There has been some barriers with interpreters. There is there's a desire sometimes for family members to fulfill that role. I've seen that. Or a desire to think that you can be understood really well, or that you understand that you're farther ahead. So sometimes there's resistance of the family to bring in an interpreter for a number of reasons, not resistance, but just they haven't identified the need, where I'll say, I think we really need somebody, and have them brought in. But then it's just also establishing that, like making sure that somebody is able to come in, and that's not also creating a barrier because we're trying to find another service.
Right. And before COVID, was that in person with the interpreters?
Yes. It was
Okay.
all in person. Yeah.
Great. So now I guess you could Zoom the interpreter in to a session.
I haven't had that experience yet, but I imagine it's another delay,
Mhm.
right? In terms of, I mean, I think it'd be feasible, but I'll let you guys know how that goes. If I have a three-way, I mean, it might decrease some barriers, but I wonder about sometimes technology already creating a bit of a delay in communication. Sometimes there's a gap.
Yeah.
So, so just looking at some of the questions.
Yeah.
So that's a really good question about training. So we do lots of cultural sensitivity training, like in relation to whether it's the LGBTQ community or now being on the newcomer group, we're doing our advocacy for our own training. But I think we're miles away from where we need to be honest. Like we are, you know, a relatively big agency, but there's a very wide population. And I think that even in our efforts to do well, we still lack, even I did a presentation and I had an Arabic interpreter there supporting, and, you know, felt because there was people within that presentation that didn't understand English or Arabic wasn't super helpful. So I think like even in our efforts to be helpful, we're missing some stuff. And I think that we need ongoing and better training on all, you know, cultural sensitivities. But I mean, being in counseling services, the respective of people as individuals is a training that's ongoing, not specific to the refugee community.
You mentioned earlier before I think we started that you had taken some training online.
Yeah, so there is some training online that it just circulated through our work, and I don't think there's a barrier to. I don't think it's a criteria, but there was one specific to refugee mental health, which I recently took. It's Immigrant and the Refugee Mental Health Project. And I felt like it was very really informative and really helpful, and just kind of lent to the need for more and more training in general. So I was just trying to find a link to it right before we opened up, because
I think we can get that out. Yeah,
Get that.
but I think it was like it was just there was one specific to mental health, and then there was another one that was specific to anybody working with any newcomer family. And I went into it with some information about newcomer families, specifically thinking I would need lots of that information, but I also felt, even just as, you know, as a mental health professional, there was still information that was valuable outside of that I was glad I took. You know, sometimes you go into it with, oh, I'm going to know this stuff. And it was nice that I walked away going, oh, this was actually really informative. So
yeah, it's good. There's some other questions on the chat. Yeah, and feel free to ask your questions out loud or put them in the chat section too. Do you have any staff that are?
Mimi's question is so great.
Yeah.
Not enough. No. The answer is primarily no. So she just asked if we have any staff that are people of color, primarily Black or Middle Eastern. No. We've been around for a really long time in this community, but not. No, we haven't even had any recent hires in our main counseling services. We're not super multicultural at this
Is
point.
that something that you guys are looking into in like succession planning?
I have no idea. We have a new executive director, but I do think that's like something that needs to be addressed well above me, and I think it would be very, very valuable. We serve, I see families from babies all the way up to 18. Someone just asked for the oldest child I see, and we now have some transition services for kids older than 18. They're not ongoing services, but they're specific walking clinic counselors where somebody older can have some transitional services with counseling through that. And they can make kind of, you know, reoccurring appointments with that counselor, but open files with specific is 0 to 18.
And how can someone make a referral? How do we access your services? How can we help people do that?
So, I mean, typically, children's mental health, if you're able to, you can just call the main line at any point and leave a message saying, I'm having struggles with my child. This is what I'm concerned with. And you will get slotted into a time slot with a mental health access counselor. So we all rotate through, thank you, yes, that's the number. We all rotate through mental health access virtually on the phone. So sometimes I get through Zoom, and we typically, those are now kind of appointment based. So, but if you phoned on Tuesday, you might say, well, we have somebody at 10:45 and one or 3, or we have someone tomorrow at 9 a.m., 10:45, 1 and 3. What would work? And you could get slotted in that way. And that's a good, we want that service to be helpful in the moment. If there's a specific concern. And it's also, so it's a one-off session that upon conclusion, it can be decided to go on to ongoing. Obviously, if we're talking about needing an interpreter and wanting to support that as soon as possible. So we have a manager, her name is Margot Beach, and she can be reached through that same number, who can support where more is needed for a newcomer family, like there's a language barrier and we need to access an interpreter prior to a meeting, because that obviously has to fit with that interpreter schedule, and there's just a little bit more to kind of figure out. It can't just be, phone tomorrow at 9 and we're going to have an interpreter that we have on staff. We have to actually access that and have them come separately. I think the question, do you also provide support for the parents, like parent counseling? I would say that, I want, 99% of my work to be parent counseling for kids. So yes, it's a resounding yes. Because as we know, the stability of a parent is most important in supporting a child. And there's a lot of education. And I mean, in our community, in outside of newcomers, even within our agency, especially when there's even the inkling of negative trauma impact, that major success can happen in counseling and isolation. So my current capacity to meet with most people is once every 2 weeks. And if you imagine having to support a child that needs to be, needs some understanding around where some behaviors are coming from in terms of their life changing, and I create a lovely place of safety once every 2 weeks, how effective is that going to be, and all the time in between that? So yes, so much of my work, and I think parents need to know coming in, is working with them in having a different perspective around behaviors, having different strategies and to support kids, and knowing that that they are the experts on their family, and that I'm a part of that team, not the magic wand I always want to be but can never be. Because I think there is this idea, there's a movie view of counseling where someone gets dropped off and they have this miraculous hour and it's great. But in specific to creating safety around trauma impact, I feel like it's almost unethical to work in isolation unless you can't. I work with lots of kids in isolation, but we know it's because nobody can support them. And we have that conversation, and then send them out into the world with nobody else reiterating that they want to support them and create a place of safety the way I'm saying they should be in my office. Does that make sense? Like, I don't want them to leave and have other things happen or other messages being sent that are damaging after I'm telling them, well, that shouldn't be that way, and then letting them go to have that experience. I'm just looking at the questions here.
Good question from Mimi there. About helping newcomers become more comfortable with the idea of accessing mental health service.
I think the reality is this is completely confidential. The only time any kind of other service needs to be involved is that if someone is harmed in some way and someone is being harmed. However, even in that, I mean, there's tons of families that I work with outside of newcomer families that, you know, some of their parenting practices would be considered unsafe. What I want parents to know is that we're not affiliated with other agencies. We don't have a direct connection. We don't have Child Protective Services with us. And all of those families that come, even with unsafe, emotional or physical unsafe parenting practices, are coming from a place of they want things to be better. And I know they want things to be better. And the fact that we're there and talking about different ways is moving in the direction of things being good. So I think knowing that this isn't about someone telling them what to do, it's about figuring out what's going to help them, and them knowing that this is just a service to support them and their family, not someone that has any definitive answers. Most of the families that maybe it's, you know, it's indicative of the people that access services are the people that are quite informed about children's mental health. So most of the families that I work with, that I have worked with, we're quite educated about mental health services. Is anybody, has Dr. Khan hopped on yet or anything? I just want to make sure.
Should any minute now, yeah.
Okay, I just wanted to make sure I'm watching it.
Yeah.
Yeah, so I think most felt like this, once some of the maybe misnomers or barriers around children's mental health were addressed, they felt like this made sense in terms of supporting their family. So it's just, maybe it's normalizing it. Maybe it's, you know, letting them know it's confidential, that no one needs to know, or, you know, if they have somebody supporting an interpretation that they might know somewhere else, I have that conversation, because typically things overlap. Like a resettlement worker might also be providing translation services. And so I have a big discussion around confidentiality, and that this doesn't have anything to do with resettlement work, that this person's here. And there is no information in this room that can go, even your fact that you've come here to access services isn't something that can be shared with other people. And I think that just helps people feel like they're safe in saying whatever, and that they don't have to worry about. And then I'm very, very clear about what my duty to report is around specific things. But also that it's a rare situation that children are taken away, that it's not something our community would want to do. And it's a last resort, you know, based on some pretty significant factors. I don't know if anyone's aware of what child protection service is, but even the idea of getting them involved in situations that I consider high risk is actually quite difficult. You can assure them that they're spread too thin and that they're not getting, like, I don't mean to be glib. I just think it's a reality that, you know, there isn't a lineup of social workers wanting to investigate things that aren't. And I guess that's just about education. But I think, to go back to what Mimi actually asked, is that if we can figure out a way to connect with people, connect with newcomer families in environments that they're already feeling safe and supported in, that would be a way for them to get more information and maybe some peripheral support in terms of about mental health or about parenting practices or whatever. And then that would be the bridge for them to show up for me.
There's one more question there from Carlin. Programs for children.
I'm just reading this, sorry.
Yeah, no problem.
So Carolyn, that's actually a really nice point. I think one of the things that I think what I know more now than maybe I did before trauma work is that kids are quite resilient, and sometimes we hear about experiences that they've had, and we can make some assumptions around the impact of trauma within those experiences that may not actually be accurate. And I've done this in my work, and I think it's natural to think about how somebody has experienced things and how this must have impacted them. But I think one of the things I'm learning is that when children's parents are safe, and when they have created they're settled in a community of support, that there is less, the repair that happens in those experiences can be really valuable. The second thought I have about that, though, is that it is really important to keep having hard discussions. That part of what kids are really good at is putting away things until the impact is something they can't deal with. So, you know, you're right, having an opportunity to have discussion about, or some kind of normalcy around, it would be hard to miss things and leave your country and all of those things, and having those be normal discussions with a child. And I think that is something that could start more at home, and to have parents recognizing that within their struggles, if you have kind of normal discussions about what's been hard and what's been easy about leaving and relocating and all of that would be really helpful. And it's educating, I think, from the home to give kids a place of safety for so when something does come up, they're okay to ask it. And I would say the same thing about, we have a real reluctance sometimes if things seem to be going well to bring things up, but I would say the same thing about death and dying. I would say the same thing about puberty. I would say the same thing about divorce. I would say the same thing about like a million drugs and addiction. We avoid certain topics, and including trauma and traumatic experiences. And I think if we just created some normalcy in these being okay to talk about, it would be very helpful.
And do you want to mention your play-based art therapy?
Yeah, so over at Immigrant Services over here, we run art and play-based therapy groups with children who came to Canada as refugees.
Mm-hmm.
So far we supported around 70 children.
Wow.
Yeah, it's been quite busy. Yeah, and we make sure we do our best to include their parents or some sort of adult caregiver there.
Yeah.
Just because really the largest predictor of children's mental health is really their parents.
Yeah. I'm so glad that you said that. Yes.
And Kristen, later on in this meeting, Kristen will be joining us. She's the art therapist.
That's so great.
So she's coming in probably 15 minutes or so.
Yeah.
But that's been a good program because
I think that what's important is if there is existing services where we could offer some partnership in education or in, providing some peripheral service to families, that they're informed about who we are and what we are, and that they consent to that, and that they develop some comfort level, of this person is coming because we do the same thing with physical health. Physical health, we get you a doctor and everyone wants a doctor. And then I just feel like mental health somehow gets stigmatized. I don't know why. I guess I don't know why, because I work in it and I think it's completely normal. But to not normalize it and have it be a part of, if you've had significant struggles in your life, emotionally related to experiences, any experiences, COVID being one for you and I, it might be good to have some understanding of how this can affect your mental health and emotional and well-being or otherwise, and know where to get some help if you need it. So we're open to connecting.
Great, thanks. Is there any other questions for Tabitha from the group here?
I was wondering, so in our work, we notice a lot of things that different cultures are more prone to say. For example, we've recently been talking about in the office where sometimes a lot of our clients would talk about death very lightly, more lightly than we would say. So if they aren't able to fill out a application that day, they'll be like, oh, I'm just going to go home and kill myself.
Mm-hmm.
And it's how do we handle that, and when do we know what's like the line that we need to be concerned?
I actually think that, again, that's about normalizing the conversation. Is that, like, I in that situation, I would actually pull somebody aside and say, I just don't want to assume that you're just saying that, like, kind of jokingly. If you're overwhelmed, I can help you with a form if that's all this is, and you're just kind of like saying that in an overwhelmed moment. But I also want you to know that if things are that overwhelming, that and you feel like this is a bigger issue. But I would actually at one point, if I heard that more than once from somebody, I would actually pull them aside and say, I'm concerned and I just want to make sure that you're safe. And like, I want you to know that I care if this is something that you've been thinking about. But again, I work in mental health services, so it's pretty normal for me to have those conversations, right? But I also think like what I want to give people permission to is to not force other people in the conversation, but to make it okay to talk about. Even my recent trainings through grief and loss trainings, I can actually, what I'll do is send you guys some links to think about, because there's some free services around even grief and loss and death and dying that I think are so great that I found recently. But opening up the conversation around those things is so essential to just normalize that it's okay to talk about it. It's okay to talk about a person you miss. It's okay to talk about loss. It's okay to talk about questions around that, whether that, and to make it okay.
Are there any peer-to-peer discussion groups for children who are former refugees?
As far as I know, no. Is that, yeah, like maybe that's something we should be thinking of. Not through our agency. I know that there are youth groups and things that used to run. And again, that was, I think, what I would want in that, because I would love to create a situation where children's mental health was involved with or a part of a group. Saying that, knowing our resources are limited, but I always want to do everything. But it's that idea that families are saying, this is what we want, that we think this would be a valuable thing for you to participate involving our child. So there was an idea before that we would kind of attend peripherally to like a local youth group and be a peripheral counseling support. And some of that might be for the youth workers to have information about trauma and mental health related topics. And my reluctance to that was, this is a place of safety for these families. And I'm only showing up if they go, that's okay. I'm okay that if someone, provides information to these people, or I'm not okay that that person talks to my child about anything mental health related. Because the last thing I want to do to somebody that's had their life turned upside down is disempower them further. So I think that's just a part of it, is I think when people feel in charge of their families and their life in a positive, proactive way, and if that's how they can access mental health services and feel that way when they walk in my door, like I already can't understand what you're going to say, which is to me horrible. Like, because if I imagine for 1 second trying to talk in a different language or have an interpreter tell people what I'm saying, it's so frustrating and exhausting and just this whole other effort. So I think it's just making sure that throughout that we're not identifying a need, we're saying, here's a service that you're able to access and I would like to support you feeling comfortable in this, if you think this would be helpful for your family. Because really what might be a priority for that family is groceries, no matter what we think. I see a million mental health issues that I want to address and then end up giving people a grocery card or a housing number and know that that's where the priority is, or provide respite or a volunteer service that they can, enjoy an interaction with an adult. And that's actually supporting their mental health, right?
Yeah.
It actually is.
It's good stuff. Thank you. Yeah, thanks. We want to welcome Dr. Khalid Khan.
Nice.
Thanks for coming.
Thank you for having me.
Yeah, we're already deep in the discussion now, but could you introduce yourself a little bit more and tell us about what you're doing?
Yes, so my name is Saroj Khalid Khan. I'm a child and adolescent psychiatrist and also the chair of our program here, the Child and Youth Mental Health Program at Kingston Health Sciences Center. I'm also active in the community with the Islamic Center, as well as done some work with with some of the Syrian refugee families, with the work that Rasha and Helen do. So some of connections there. But we're a tertiary care center, and we provide services for psychiatric services for families, basically the adolescents, but we have a family-based program. So it's really looking at the whole family and what they need. So it is a subset of the population that we see, and we have strong links with the community partners, so that the links are such that the people that only need to be seen in such a complex, or if they have done the services or utilized the services in the community first, and the primary care, and they're not doing well there, only then they would be referred to us. So really after they have gone through things already, we wouldn't see them right away, if other people can first provide that treatment. So the least intrusive would be involved first. So the links help us get the person to the right stage, hopefully.
I'm going to put a question to you that came up earlier when we were talking with Tabitha, and it's about how we can help newcomers be more comfortable with the idea of accessing mental health care.
Yeah, I think, and I just saw a question, is there an Arab-speaking adult psychiatrist in Kingston? I believe there are. The difficulties are that psychiatry program, like other programs, were spread over 3 hospitals.
Yeah.
And so, it's all the inpatient services, as you know, are at Kingston General. All the outpatient ambulatory services are at Hotel Geo. And then there are some chronic care services at Providence Care. And people that need acute treatment will only access the KHSC, the Kingston Health Sciences Center, which is amalgamation of Hotel Geo and KGH. So the Arab-speaking psychiatrists some of them are positioned more at Providence Care, where there's forensic psychiatry or mood disorders that are more ongoing in a more chronic way. So we don't have, I believe, anyone in the acute clinics that a psychiatrist that speak Arabic, but then we always have senior trainees that are Arab speaking. However, you do have to be a little bit careful of the political connotations of that. If they are from a region or from a country that there was conflict with, or there was, they're maybe not taken on even. I think to Tabitha's point, we have difficulties accessing interpreters in a timely way. And it's not really helpful to have just plant anybody into that translation or interpretation role, because there may be conflict seen or perceived conflict that we weren't aware of. Mm-hmm. If someone is from a country, like for example, most of our trainees are from Saudi Arabia, it may not go well for Syrian refugees to have someone like that translating. So, it's just some things we wouldn't even, but to meet them where they're culturally attuned to that person, that's the biggest I would say hurdle. Even though we may be aware of, like I may be aware of those things, but how to make the system be flexible around that is a really tough thing. So I don't know if I answered the question. So if the services are needed, we would try our best to accommodate them in the general fashion, and if we had a notice beforehand. So sometimes the people who are helping the family navigate, or the adult to navigate the mental health services, then they would give the heads up, and then the clinic will do their best to get someone and get more people involved that would help that family or that adult coming in for services, but definitely children. There's always someone accompanying children. So I think there's a little bit more preparedness, because just by default, there's more community community and members involved. So when we've had a few families come in, there's always someone from the sponsorship or families that are helping them, or there's someone from the immigration services. So it's gone relatively smoother than maybe an adult who may not have that. But from what I have seen, families are pretty nicely connected, though. There's always someone accompanying.
How are referrals made to you then? How do people find their way?
So for referrals they haven't been that many for if we're talking about Syrian refugees. But when they have been made, they've been made by family doctor.
Mhm.
And a couple have come in. Actually, I've done a group at the immigration services with Syrian women, and I had been involved, and I felt that person needed to be seen, and then I kind of encouraged them to come in, and I did the assessment here, and then referred them on. And then there was someone anticipated coming in recently. The adult side was trying to get me involved. So we try to have a point person to help the rest of the team, which I guess I'm the one here in acute services so they tried to get me involved to see what could be, make it more welcoming for them, and who could be the psychiatrist out of all the psychiatrists that don't speak Arabic, who could be more culturally attuned. So we try our best. It's not the best thing that could happen, but at least we try with what we have.
That's good, thank you.
So I was wondering if maybe our settlement workers can answer this, Rasha or Gayatri. Do we have a Arabic speaking therapist at Resolve Counseling? Cocos.
There's a counselor at Resolve who speaks Arabic. She's the only one, and I know she's overwhelmed with the demands. So they try to get other people to see clients with certified interpreters.
All right, so Dr. Khalid Khan, the question earlier was about helping to normalize mental health care with newcomers. How can we, us, the frontline people, sponsors, settlement workers, how can we help remove that stigma that seems to be there?
Yeah, I mean, I think some of the stigma, I mean, I guess is coming from what I've seen is internalized already by the newcomers, that saying anything around mental health is considered, that you're going to be considered crazy, or it's just not something that you do. So it's just normalizing it in a way of initiating conversation, right? And then I think that first contact of just having a conversation with the person to say, these are stressful things you have. I think putting perspective to their experience, because when someone is living through such big things, they're not really thinking about it from a different perspective. And when I'm meeting families like that, I'm just in awe of what they've gone through. And it's just like, how are they even, coping? So maybe giving some perspective to them that, wow, you've gone through so much, and it would be understandable if you were stressed out, and having, I think not using labels too much, but, framing their experience in functionality and stress and distress, right? I think using words like that, when I kind of was in that group, Rasha would translate for them and make it more normal language and more experience, but I try to frame it in functionality and distress rather than diagnoses and names of disorders, which never goes over very well, because number one, I've not assessed them, and that doesn't mean anything to people who don't may never have had that experience of going to anyone. And always mindful of maybe even trying to hide the word psychiatrist is even very intimidating, right? So it's not always the most, the first thing that should happen. Maybe having family doctors, maybe taking the first step, because many family health teams have a lot of support for mental health. So making it the least intrusive. As soon as you come to a hospital, there are so many negative memories or what have you involved with that. And just the name of seeing a psychiatrist means so much more. So I think if the treatment can stay at a community level, with maybe liaising with the psychiatrist if needed, and our community does a very good job of that. They know exactly when to get the psychiatrist involved. So Maltby does a great job with that, and family doctors do a great job with that. So I think that would be the best thing, right? Having a culturally attuned person, maybe talk to them, and language is one thing, but also cultural attunement at some level is important, but keeping it into a less intrusive stage, it would be the best thing.
I'll ask Rasha, when Dr. Khan is talking about the women's group that you guys participated in together. Did you notice something from your end, Rasha, at that group that helped normalize having conversations about mental health issues?
Yeah, that's exactly what Dr. Khan did. So what she did was just elicit their concerns, and it was basically parenting concerns, like what struggles are they having raising teenagers, raising kids, whatever concerns they had. And then she would casually address that conversation over a meal, and she'd just talk about it generally. And what she did that I found eye-opening was she started empowering them. So she would, they would address a problem, and then they would share. Some of them would have the common problems or same problems. And then she would then ask them, how can you help this person? How can you help this mom overcome this problem? So they've already formed a community within the group, and it is a safe space. But now they're actually trying to help each other, given the skills and the knowledge that was brought in by Dr. Khan. So it was great. It was very very useful.
Mm-hmm.
I think I must say that they had, so this is just for everybody, this was a grant from Community Foundation of Kingston, and it was for the youth having them connect. How do we connect them to the community better? But we decided to, when we problem solve, we decided to meet where the family was at. So I decided first that parents are more important. So Rasha already met with them. So there was trust there. There was just a nice group of, just collegiality there. So we kind of descended, me and my assistant, we just kind of descended there and met them where they already had that. So I think that was where it worked, because they already met, they already were friends with each other, and they were very comfortable with Rasha. And just putting on another piece to that was they were learning for their citizenship, right, Rasha? You were helping them with their citizenship test and practicing their English. So and it became like a joining together over a meal and talking about different topics, but doing it in a very non-threatening way, in a very relational way. And I think that's kind of where it became apparent that, and I don't want to kind of give away anybody's confidentiality or privacy, but one of the women was really struggling in terms of some losses and what they had witnessed and all that, and it became apparent from conversations. Right. So I think we were able to do some targeted intervention. I mean, again, the community is so on top of everything. She already had gone to a family doctor and was getting the right treatment. It was just the follow through of just encouraging that you're on the right thing and you just need, you know, more support around this and validating the experience. I think that's what was needed more than, you know, just so the work had already been done. It was just kind of going forward with more.
Yeah, it seems to be that building of that trust seems to be pretty important. Dr. Khalid Khan, is there one piece of advice you could give to us settlement workers and sponsors from your perspective that could help us serve refugees better?
Initially, when I saw the process, I worried about, this was 3-4 years ago, I worried about dependency and when everybody would be left, when the families would be left and what they would not be able to do. I think my mindset of, you know, how we work with families, you want to make them more self-sufficient. But over time, I've seen the bonds that are created with the sponsors and with people who are on the ground working with these families. I mean, there's real trust and there's real caring, and it hasn't resulted in dependency of families. It's just become like a bigger family, right? And people have kind of allowed the family to grow and get a job. So I mean, I've seen that. So that's been really, really nice, and I've learned a lot from being. You know, I miss those groups, and I really miss a lot of the good stuff that's going on. So I don't know if I would give any more advice. I just think that making mental health part of the discussion and just an everyday discussion. And I think they are getting that, and not making it like a hospital thing. It's just everywhere, and it's okay. We all struggle with it, and it's because in those parts of the world, any kind of psychiatric visit is considered crazy, right? You're crazy. And what does crazy mean? A major mental illness, right? But that's not what happens. Most people, all of us go through anxiety and depression at some point in our lives. And just even saying that. Mm-hmm. And all families need help at some point. My own family, you know, we all need help at some point, and it's okay. Mm-hmm. I think that part of and bringing service to them rather than having to, if you don't have to. Now it's even harder with COVID, but even coming to a hospital, it's very intimidating for people. You know, in general, kids have bad memories at hospitals. You get shots and you get injection, and for people from war-torn areas, it's even more, right? So if we can do more in the community and bring what's needed to them, then that would be the best way to go.
That's great. There's one more question before you go. I know you have to leave pretty soon.
That's all right. I think I'm okay to stay for a bit longer. I did what I needed to do, so I'm not pressured.
Great. There's a question about things to watch, behaviors that you should watch out for, questions that that could be, it's from Liz there. Just behaviors to watch out for, questions that could come up in conversations.
So the biggest thing to watch out for people who are gone through some terrible things, that traumatic things that they have, and I don't know if Tabitha, you already talked about that, but you know, traumatic things that people have witnessed and losses that they have gone, we find that this is the most hidden diagnosis and hidden illness because people can be triggered from nowhere, literally anywhere, right? So the triggers can be in everyday stuff, a little noise, a little smell, anything, any of the senses can bring you back to that traumatic event where you could have a big flashback and you actually can act as if you are totally not yourself, right? So it can bring a lot of shame and loss of control, and so I think beginning to kind of ask, being aware of those situations, that people can be triggered for little things, and their irrational behavior may be due to the trauma that they have experienced, and that often it doesn't come out. People are not ready to talk about it. And also people are not used to asking you wouldn't be, it's only, people who are trained to ask those questions would be asking those questions and looking for them, right? So I think that's the biggest thing of, and we call it post-traumatic stress disorder. Not everybody is meeting criteria for that, but the triggers can be everywhere, and people are on a spectrum of that. Like some people may have just nightmares, but others may be triggered every day with little things that may be there. So you may be doing something nice, but that could trigger an incident for them.
Mm-hmm. We also want to welcome Kristen Dillenbeck, who's also, she's an art therapist and counselor.
And a psychotherapist.
Yeah, and a psychotherapist. She is. So feel free to join in the conversation too. That's a good question too that you could add an answer to if you'd like. And we want to, and Tabitha, you can join in too.
I just wanted to add one thing before I I think the other thing to not do is go where the person is not wanting to go. So I think many therapists, myself included, when we know the person has a history of trauma, we kind of go after it. We think that's what's the major driving factor, whereas people may have coped with it and they're fine. That it's not the main thing they're dealing with. And we may keep going there and they may not want to, and that can cause more trauma. So I think that piece is the most valuable piece of information to keep in mind, because many times that happens, and it's not a good thing. It doesn't actually build alliance. It actually breaks the alliances with the therapist.
Mm-hmm. So I think we need to make sure that we're careful and we're not re-traumatizing individuals.
Yeah. I also think, again, just to reiterate, we're not making assumptions about what was the traumatic experience. I've worked with lots of families outside of newcomers, and with where we identify what we would consider the most traumatic event for somebody, and it isn't. It isn't even on their radar in comparison to this other experience. So it really is about, if you are going to do trauma work, not making assumptions, and knowing, what I do know is that if the behavior seems strange, if you're going, why did you, this doesn't make sense, it can be about a trigger or a relation to something else. And if you do it like, how would this serve somebody? How would this behavior serve somebody in a different circumstance? It would make complete sense. So you look at the behavior that seems out of the blue and unexpected and go, why would this be this way? And then the next question should be, oh, this makes sense because this might serve somebody in this way. If it doesn't make sense in that circumstance, it's often related to a very important survival behavior from a previous time. That's my experience.
Mm-hmm. I would totally agree with that. I think away from this population, just in general, what we think, we always go after the big incidents, but the most traumatic thing generally for any child is more the bullying that has happened or ongoing. That's caused the most trauma for them. From your peers, it's just devastating. Whereas, in our minds, it's something else. I'm not saying that that's not important, but that is more embedded and more it's going to have long-term work that needs, but the bullying is the most traumatic thing. Mm-hmm. And it may be for these families, these kids, that they're coming in and that's where they're spending their time at school, and that the acceptance and the everyday stuff. Mm-hmm. That's the most important. Whereas we're thinking, oh my God, they've come from a war-torn area. What does that mean? That's not the same for them. They're trying to fit in. They're trying to just be accepted. And by not having maybe that's the most traumatic thing, and may lead to other things, but that's on the surface. That's the most important. So meeting them where they're at, rather than having our own agenda, I guess that's what we're saying.
Yeah, completely agree.
good. There's a question from Tarek there about differentiating between a person staying home due to unemployment or lack of English skills versus being depressed. How could you make that call? What would you see the difference there?
I would ask. I don't mean to be glib about it, but if a person was typically sociable and then all of a sudden, and then they're associating that with work, I feel like everybody needs to be given permission to be a loving, caring person. And when someone says to me, I really care about you and I hope that everything's well, but if you're saying, you know, like, I just want to make sure that you're okay and that you're at home just because you're out of work. But if you're at home and you're feeling down and you need someone to connect with, I'm here. And if it has nothing to do with that, that's great. But if it does, I'm here, and that would be valuable for you to know that. So if we're ever in a dark place and anybody came in to say, hey, is that an issue? If it is, I'm here. And if not, that's great too. It just gives them permission to reach out if they need to. I think, that's my recommendation, is if you have a concern, just share it from a caring way, not a judgmental, I'm assuming way, but I was just wondering.
Yeah, I mean, and I think it's the baseline too of that person, and the family knows the best about that, right? If someone looks depressed to us, well, what were they like before when everything, they had the language and they had employment? What were they like? And what's changed now? And, you know, what are the things? Are they wanting to do things, or they just have no desire to, you know, if you could, what would you do? Do they have hope, or they've given up hope? You know, are they excited about the possibility of some things? So I think those are the things when people have given up on not even wanting to go there, or wanting to get something, or wanting to achieve something, which can be, you know, when you've been at, you know, in a family, you could have some, you know, the immigrants, you know, of all ages, right? So someone who's been at a very high achievement level and now they have nothing. You know, that doesn't mean they're depressed. It's just that's where I guess the question is coming from. But functionality is what we base it on. But with COVID, I think we have to reorganize all our ways of assessment. You know, people are not going out as much. There's not much to do, even if you wanted to. And then on top of that, if you don't have the language and you don't have employment, that's even harder, right? So yeah, it's another layer that's added on to it, makes the assessment even harder.
Can I just ask Kristen to introduce, from a very selfish point of view, can I just ask Kristen to tell us a little bit about yourself and a little bit about the group and what's happened over the last couple of years?
Yeah, absolutely. So I am an art therapist and a psychotherapist in the community of Kingston. And so I met Ujir a couple of years ago when she was interested in seeking out some services in terms of art therapy. So we kind of sat together and hashed out what would be the best in terms of fitting the need for what was going on, what she was seeing is coming in, and what was some important aspects to kind of provide support and a bigger network for in a different way. So we came up with some groups for art therapy. The COVID landscape has changed things a bit, but historically we were having children and families come in. It was more of a closed group. So we would have a session of 8 to 10 weeks. I think we stuck with 8. And they would come in, and so we would really we would have different art directives for them to join in on. And so the group was really, it was a really beautiful thing to watch. It was a really different way of setting up a group for me in my experience with art therapy groups. But what it ended up kind of turning into was more a group about connection and community and building resources, and really noticing that a lot of newcomers were having trouble. Either it was a language barrier or also cultural. admitting to when they're not doing well, right? So it was a lot of, we're happy, everything's fine, it's happy, we're in a happy, good place here. So it was helping them develop emotional language, and also giving them a space to voice whatever was going on for them, if it was going on for them. And so, yeah, and using art as a way to connect and communicate, and kind of get out what's going on internally for people, but a good spot to connect and build community. So we started doing that. And then when COVID hit, we shifted it more to individual. So we just have an individual family, and we moved it outside. So now we're doing more eco art therapy oriented activities. So that's including a bit of hiking, and then also integrating that with some phototherapy. So that's what it's just currently just a single session for any given family that kind of comes up with, I guess, I don't know how Yurjir finds them, but yeah, but that's kind of what's happening now. Does that kind of summarize it, Yurjir?
Yeah, I think you got it. So I think Liz asked, is this sort of therapy supported by OHIP? No.
Oh, no, unfortunately not. Yeah.
So interestingly enough, so IFHP, so Interim Federal Health Program, that newcomers get within generally their first 3 months or so, does have some money for some forms of therapy and some counseling sessions with social workers. But that is for a very short period of time, and you'll have a very hard time finding a therapist or counselor who would be willing to accept this form of payments, because it's just really another insurance company that is really hard to get paid by logistically. But it is arguably an option if you look around.
It's probably something that sponsorship groups should budget in for.
Mm-hmm.
Mimi's not here, but it would be a good thing for groups to put in as part of their support for that first year, is put some money for that, some counseling aside. Yeah. Any questions from anyone out there? Maybe I'll ask Kristen, could you maybe expand a little bit on what an art therapy session would look like, just to paint the picture, so to speak, a little bit better? Yeah.
Yeah, good one. Yeah, it's really different. I love this question because it's so unique to each individual and group. So how I operate within it is like kind of in a 1 minute elevator speech. There's kind of 2 avenues for art therapy. So there's kind of art as therapy, which is just coming in to create art as being intrinsically therapeutic. And then the other avenue is art therapy, which is more looking at kind of the introspection and what's going on during the process of art making for that person. And then you would take a look at that and talk to them about it. So depending on what the goal is, so if it's a group, you would ideally sit down and kind of say, okay, what do you want to get out of the group? What's the point of this group? And then you would cater the art experience to that goal. So it looks really different if it's kind of an anxiety-based group versus a connection group versus a trauma therapy group versus on and on. So so it will look really different depending on what you're attending. And then in the same stream, individual art therapy is mostly what I do. And so again, it really depends on what the goal is for the person who's attending. So if it's more self-exploration, or there's some depression pieces, it would look like, so you would come in, we would talk about what the goal is, do a bit of an assessment around that, and then move more into the art therapy, which would look like potentially a spontaneous art therapy, potentially directive. So if it's like, actually, I think some of these really pertinent kind of maybe mindfulness-based stress reduction activities would be helpful, I might incorporate that into the art. Or if it's more cognitive, so either a CBT model or a DBT model that I might be catering some art therapy into, then I might give you a more of a directive and say, okay, I want you to create what a safe space looks like for you, or what your family, who's all in your family, and what's that connection like for you. And so then we would give space and time to physically make the art. And then we would come back and I would ask those kind of questions about what it means to you and what their associations are about the art. Just to develop that introspection and self-awareness piece. So it looks really different always. So I can't answer that for you too specifically, but that's kind of the trajectory and flow of what you could expect. Do you have questions about that or curiosities? I'm happy to answer anything.
Yeah, go ahead, anyone. So I know when Jer comes back from some of these groups into our office, there's like sometimes really interesting paintings that the children have done.
We share an office and our office is a mess.
Yeah.
That's why they put us together.
There's a lot of craft supplies in our office.
Yeah. I bet that's my fault. Yeah.
I think this is a great example of a non-stigmatizing way of bringing mental health, experience to people, which is how it should be. It shouldn't be an experience of sitting face to face, talking about traumatic events that people have gone through. It makes it so intimidating.
Mm-hmm.
I think this is a great example of how it should be.
Yeah, that's a good word.
Mm-hmm. It's a good way to break communication barriers too. Mm-hmm. I mean, we always have an interpreter available and with us, and so there's that, but then also just the way we communicate through art is universal. So it's a good way to connect in a way that doesn't necessarily come from a language-based place.
Exactly.
Great. And Kristen, what one piece of advice would you give us, settlement workers, sponsors, support people when we're working as non-professionals with the refugees?
Yeah, I saw that question and I was pondering, and the biggest thing I think for me is to listen. So to not come in with your own agenda, and to come and just kind of ask questions and be curious, just genuinely curious about another being, and listening to what they say. So if they are like when Tabos kind of answered that question about how do you do something, and she's like, oh, just like ask. It's like, right, yeah, like sometimes it's really just that simple. So just being available and holding space to listen and ask questions and be curious, I think is the biggest piece of advice that I would give from my lens. And then I guess the second piece would be to normalize too. I noticed a lot of it is cultural and it isn't, because it's also like the general public does not love that discomfort of going into therapy. And so to be able to normalize, and it's okay to seek support, and it's okay to not be okay sometimes. So yeah, it would be listening, validating, and then normalizing.
Even normalizing from that sense of like, so there's normalizing what somebody's going through separate from anything to do with being a newcomer family. Like I know so many people that have a hard time like halfway through winter in Canada, and we make sometimes an assumption that their difficulty going through winter has to do with this new climate, or whatever, or it could just be that it kind of sucks sometimes mid-February for everybody. So I think for me, it's like, it's normalizing the idea that ups and downs in our mental health are just there. And that as we have discussions about them and what works for different people in terms of keeping themselves safe and keeping themselves hopeful and keeping themselves engaged, is so valuable to just be able to talk about and to generate that in those relationships you're closest to. So if I can facilitate that for somebody, I want them to be able to take that to their good friend or a worker they're visiting with, day to day. Because it might not necessarily have to do with, always have to do with them also being a newcomer family. That makes sense. It's just being curious being curious and asking a question in just a thoughtful, caring way, and not a question like, I need to know the answer to this because of your potential trauma background.
Yeah, that's good. Any advice from others? Because I know there's sponsors, settlement workers, you've all been working face-to-face with people. Is there any advice you give the rest of us in the group here when it comes to mental health issues? Feel free to share.
I can share something. So with another thing that I found important when I was doing the women's group is the importance of self-care. So most of them are moms, and they go to their ESL classes in the morning. They're running to go cook a meal, and then our group starts right after that. So they like coming because it's a space where they can, there's no responsibilities or duties anymore, and they can just kind of be who they want to be. And a question that I'd always ask, what did you do for fun? And it's interesting, like nothing. I didn't have time. I was cooking. I was so it's and just reiterating the importance of taking care of yourself so that you can take care of everybody else around you. So that was important for them. And then they eventually figured out too that just like even a walk for 10 minutes can make a difference. Things like that.
That's good.
Can I ask a question?
Yeah.
Russia, are you running these groups still through Zoom, the women's groups, or any groups up there?
I attempted to do Zoom. That didn't go well.
Didn't go well. Okay.
So
Thanks.
yeah, so we're going to hopefully in January start again outdoors, kind of like what you, Jer, and Kristen were talking about, the walk.
Yeah, Kristen, we need to talk afterwards about that. Sorry.
Guys.
Rasha, can we also talk about continuing, because we still have to do our.
Yes, for sure. Yes.
I think adding some art therapy to that group would be amazing.
Yeah. So I attend those art therapy sessions in person. Of course, it's great, and even the Zoom is it's nice to see that connection developing between the kids and their parents, because they never have time to spend together because everybody's busy trying to get things done, right? So during that session, whether it's Zoom or in person, it makes you sit and actually do an activity together, and it's great. It's great on both ends, parents and kids.
That's great. Yeah. Any other suggestions or pieces of advice?
I just noticed a question earlier from Carolyn, a specific thing. I don't know if you saw that, Dr. Khan. It was just like,
yeah, I answered her privately.
Okay, good. Thank you. Okay. If anybody, I don't know, I just felt like that was like a legitimate, these are the things we see day to day. Like, how do we?
Yeah, I mean, I think one of the things is the trauma piece. You can actually get re-traumatized, and from far away from, or for the first time, by hearing and listening to what happens to your loved ones, or even watching things on TV. So, and one of the other thing is, if you are traumatized, your brain does change for many people, and it goes into a loop, and it seeks out more traumatic events, right? It's not everyone. Most people are resilient, and we have to keep in mind that that's what happens to most people. They're resilient, they've moved on. Maybe we're stuck on their trauma. But some people do get into that loop of seeking out more traumatic things, and it's hard to break that cycle. So I think keeping that in mind, it can never be it's hard, right? They're listening to things that are happening on their cell phones, but then there's also the connection, and they're worried about family. So yeah. It's so hard, it's so complicated.
Yeah, I think it's like twofold. It's like, is this something that you've become so accustomed to, like it's such a role in your life, and how do you redefine yourself and move on in a healthy way? And then there's also this, are you providing from a place of safety, some support to like a loved one somewhere else. And I think it's that investigation around what might be motivating it, you know, from that standpoint. But yeah, I think you're right. Thanks. I just thought, I am glad you answered privately as well, but I just thought it should be talked about.
Yeah, thank you.
If I might just add to that, I think that when we've been quite involved as a group, and Kim Taylor's here, she's part of my group, and we've been involved in the sponsorship of, I think, 7 or 8 families that are here now, and several others that we're still waiting to receive. When they first came, the first family arrived sort of 6 weeks after we started the journey with them. And then within 3 months, we had 2 more families. And then we immediately initiated efforts to help to bring their siblings and other members of their family here. That was in 2016. Over the course of those 4 years that we've been waiting to receive them, ready, willing, and able, their situations have deteriorated dramatically. Some people have died, other people have been injured, food shortages, lack of health care, lots of things have happened. And as that's being communicated on a daily basis to the families that we have sponsored, I think the impact on their mental health as well as on ours, where we keep saying we're trying to help and yet we feel so powerless because we've been waiting for 4 years to receive people who thought they were coming. So this ongoing narrative of being daily reminded or confronting relatives' deterioration and being powerless to help, I think is very complicating for the families that are here and also for the families we wait yet to receive. It's been very hard on our volunteers as well, I must say.
Have you had to seek professional help at all out there in the county?
No, but I just know that there's a burnout level amongst volunteers who've prepared homes 3 times and then travel documents didn't get issued finally at the last moment, or an explosion went off in Beirut, or COVID, or who knows what all of the various factors have been that have been delaying. We've tried to get some mental health supports for some of the people we've sponsored. Mm-hmm. I would say that our ability to do that has been quite uneven, as has their willingness to use those mental health supports. We've had 2 or 3 different things set up that people went to maybe 1 meeting and then said, no, I don't need this, I'm not sick, and just wouldn't go forward with the process. But yet they've acknowledged repeatedly that they really need that help and support, but still they don't want to get it. And part of the issue is a language barrier. I think if we had an Arabic speaking psychologist or psychiatrist, it would go a long distance. It's fairly awkward, I think, to ask your brother or someone to be a translator for you talking about your own mental health issues. I think that's not really that appropriate even.
Yeah, thanks. I think we're going to try to wrap things up now.
We just have some housekeeping to go through. More housekeeping, apparently. So, do you want
I just think on that, related to that, we put in a proposal, right, for OTN. So yeah, explain a little bit more about that. So
around 2 or so years back, we had, so at Kingston Community Health Centers, where Immigrant Services is a part of the umbrella of, we have an OTN team, so Ontario Telemedicine Network team, where they are able to go further and reach further with physical health and mental health supports. So they're used to actually be an Arabic speaking counselor, and this is all paid for by another grant. So they were able to provide Arabic counseling over this big screen in our office over here for free for many newcomer clients. We've lost that funding, but we wrote a grant, and hopefully we will be in the process of getting that back. So if there is news on that, stay tuned. We'll announce it somewhere.
Excellent.
Yeah. And let's see, we're also, some of us in the office are also getting mental health first aid training. So, and at a point, we would love to roll that out to really, as many people as we can.
Yeah, some
this-
sponsors. For sure.
Yeah, this would include sponsors, some of our clients if they so wish, and other service providers within the community.
On January 26th, coming up, we've got someone from Toronto, Teresa Dremetsikas, who's going to do like a 1 hour, 1.5 hour training for us. She's from the Canadian Centre for Victims of Torture. So they do a lot of training there, but she's going to join us for a Zoom webinar and give us a little bit of training. So it's something that you might want to participate in, on things that we could be aware of, things to think about, a little bit more in depth from what we were talking today, I think. So that's something to look forward to.
And that was actually a direct result from these meetings that we had. So Steve reached out to them. And something really cool to note about the Canadian Centre for Victims of Torture is that they are the second center for victims of torture in the world. They are very big, and it's really cool that they're doing this for us. Yeah.
And yeah, so another thing, one last thing, we're going to get you all to send in questions. So any questions you have about refugee support, it can be about any topic, not just mental health. And we're gonna get answers to your questions, and we'll go to a professional maybe and get them.
Try and find the best person to answer the question.
Yeah, so it's kind of like ask anything kind of thing. So, and then we'll put that on our website, and we want to show you that before we go. Our website, we put our resource list up there.
Sorry about that. Ignore these because I was Googling. So based on these projects, we also updated our website to create additional resources for refugee supports, and with a lot more information. For example, if you wanted information on healthcare on our website to specifically support refugees, these are all the different programs with different links.
So this is on the kchc.ca website. So, and we're going to keep this updated. And so it's a place that you can go as a sponsor to find information on all these topics right here.
Things like that.
Okay, so that's a resource that we want to make available as well. All right. So yes, food, go ahead.
Okay, and the most fun part about all these sessions is that I think we've explained it a few times in the past. So Laureen and the lovely people over at Allies for Refugee Integration gave us a bit of money to help with some food supports when we run these sessions when they were supposed to be in person. But since they're no longer in person, we thought, hey, why don't we just give everyone gift certificates and support a newcomer business? So we've done Thousand Curry, we did Joe's Flavors. So this time we will be doing Jonal's catering service. So it's Syrian food. It's really great. I actually made this poster. I'm just bragging for the clients because our work is very broad.
So for everyone who participated today on the Zoom meeting, you're going to get a gift certificate for $20 to Jonal's Catering. So.
Yeah, and Jonah has actually brought in her food for us, and it's really good. I really like how not greasy it feels. That's a weird thing to say.
So I would like if Carlin Moulton and Kim Taylor, could you put your emails in the chat, because I don't think I have yours. So if anyone has never received an email from me, put your email in the chat box, and then we can get that out to you. Okay. All right. So thank you, special guests today. Thank you, Dr. Khan and Tabitha and Kristen for joining us, and for everyone's comments. We're grateful, and look forward to we'll look forward to your questions that you're going to send us, and also to that January 26th training that we're going to be doing. Okay. So thanks again, everyone. Take care.
Thank you very much.
Thank you.